It's with great pleasure that I can introduce Dr. Carole Hapchyn, and often when we do a lot of work out west, out of our office, and Carole is one of the few psychiatrists in Canada, and one of the other ones is at the back of the room, actually trained in infant and early mental health. So she works at a number of places, including Elm Tree Clinic, which is her private practice in Edmonton. She's also at the Glen Rose, which is a mental health agency. Rehabilitation hospital, and is a professor at the University of Alberta as well. And I got to know Carole years ago, but most recently, she really introduced me to the NeuroRelational framework, which I fell in love with and started to really feel like, wow, we need to start sharing this. So while this has been developed by Connie Lilas in the US, I think Carole is really the one bringing it to Canada and adapting it for a Canadian context, which I think we can all agree, we are a different place, and our culture is different, and there are some changes that need to reflect that. So I will hand it over to you.
Okay, first of all, can everyone hear me at the back? Yes? Okay. So what I'm going to do this morning is going to be a bit different than the other presenters. So I'm going to ask you to think big picture. I'm going to present you with an awful lot of information, and I'm hoping that it will be coherent. We will have a chance at the end of the day to dive into questions. So let's start. So what I am going to do is basically give you a book review and an overview of a framework that is detailed in this textbook that was written by Connie Lilas and Janice Turnbull. Connie started her career as a maternal health nurse, then did a master's in family therapy, then did a PhD in psychoanalysis, and then when she was a fellow of 0 to 3, wrote a textbook. And she wrote this textbook with Janice Turnbull, who's a neuropsychologist. And the goal was to describe a framework, which could be a map for the work that we do. We do very messy, complex work, and we need a map to sort out the complexity. So my objectives are to convince you, trying to do a little brainwashing this morning, to think about the NRF as a framework to hold complexity. I am going to present you with 5 paradigm shifts that we've been thinking about. We hold these paradigm shifts, we hold some ideas in our culture, and we need to shift. And then I'm going to describe 3 easy peasy steps, not really, but 3 steps to try and organize our clinical approach. So here's the definition of what neuro-relational framework means. Neuro refers to this framework as being neurodevelopmentally sensitive, based on a whole slew of neuroscience. Relational talks about the need to prioritize the parent-child, caregiver-child relationship, as this is in the context of which the brain grows and develops. And this is the context in which healing can occur for all of us throughout the lifespan, actually. And then framework refers to a holistic assessment and intervention practice, but we are seeing this framework as having, being on a continuum from promotion through prevention to treatment, intensive treatment. So what got me to read the book in its entirety was reading the front and then I read the end of the book. That's, my mom told me years ago, if you want to know whether it's worth reading a book, read the front, read the end. And at the beginning, Dr. Lilas and Turnbull described these barriers in our current field, and they are in their entirety here. Fragmentation. So fragmentation refers to our struggles with having cohesive and connected care for the kids and families that we see. Practitioners in our field work in isolation. We don't do well in communicating with each other about cases. Unfortunately, we have hierarchy in our field. So sometimes the folks that have the better degrees, in quotation marks, may lead teams, and they may direct care when they actually don't know the whole clinical situation and the family. And then we get into our specializations, which are great because specialization, dives deep into areas of practice. But then we all develop our own little areas of jargon, and then we have a hard time talking to each other because we talk in words that don't make sense to each other. So the NRF actually provides some answers to this. And so what Dr. Lillis and Turnbull did is they decided that they would use the brain as the template to find the solutions. And so the brain is an integrated organ, and the brain doesn't actually care about diagnostic categories, that these are just left brain phenomenon that humans make up to try and explain how our brain works. And the brain is connected to the body. So when I talk about the brain, I'm talking about the entire distributed nervous system. So the brain is connected to our body. It doesn't kind of stop here at the neck, and the environment that we live in. So the NRF holds complexity in the context of the environment. And the NRF strongly values all disciplines. So all disciplines have a place within the NRF, and we hold a value neutral approach. And there is not dominance in brain function. There is for milliseconds at a time. A different brain part will take over, but then it works in an integrated way. And likewise, there are areas of specialization in the brain, but again, a coordinated approach. So the NRF is about creating a common language so that we can all talk to each other easily and have a shared approach so that we can easily go from complexity of the whole to parts to whole, back and forth. So I've used the word framework. Framework is different than a model. A framework is a map, and this framework truly can hold all clinical models, theories, and evidence-based treatments. And the idea here is that it can guide you as to when to use an EBT or a promising practice. So you asked a question, well, when can we use watch, wait, and wonder? Well, the NRF can actually answer that question. If we assess the family and their situation and the child and the adult's capacities, then we can target and very mindfully, appropriately use the EBTs that we have. So this idea of the NRF being on a continuum, we think that we can message this very complex framework in a simple way so that we can use it at a foundational level for all practitioners. And when I say all practitioners, I mean across all fields of practice. And the idea here is that if everyone has the same knowledge of how the brain functions and develops, we can talk to each other and make warm handoffs, and then organize the work that we do for our complex families in a more meaningful way. So it helps us, and then really importantly, facilitate cross-sector collaboration. And then, as I've mentioned, this idea of the NRF being able to help us target when to use which EBTs for whom. Now, so Dr. Lillis and Turnbull wrote this book in 2009, and since then, there's been a big shift in how research is being funded in the United States, and Canada and Europe are following along. And what the bodies that are funding research are saying is that they're saying we're moving away from funding limited research that is focused on diagnostic categories, that is more laboratory-based, kind of more research think tank-based. We are moving away from funding that kind of research, and we want to fund messy, real-world, community-based research. And we are moving away from linear thinking to more of research including system science principles, which is really complicated, messy work. And so, interestingly enough, the NRF is very concordant with that kind of shift in the research world. And I will demonstrate that. I have a lovely slide to show that at the end. That's a teaser. So what's happened in our fields is that we have evidence-based treatments, but they've been very narrow in their focus. And so we have treatments for post-traumatic stress disorder, we have treatments for ADHD, we have autism-specific treatments, and we have lots of literature showing that these different treatments work. But then all of us that work in the real world go, well, they don't work so well for us in the community. And it's not because we're not following the manual. You know, and then what happens when you have one of my patients who has all three diagnoses? Then what do you do? So again, I'm going to, in my brainwashing attempt this morning, show you that the NRF can help us figure out this complexity and guide us to figure out what to do in these complex situations. So I've mentioned evidence-based treatments, but I want you to put this in the context of what evidence-based practice is. So the NRF is advocating evidence-based practice. And that means that we integrate clinical research and knowledge about the brain and development with our own professional wisdom and experience of what we know about working with families and the theories in which we've all grown up and learned to love and sometimes hate. And then blend that with what our families bring, their cultural values and our families' experience and what they're wanting. And really help our families make informed choice. That's evidence-based practice. So I have adapted this slide from a slide that I saw years ago, where the slide was evidence-based treatment, and then there was this big kind of sewage tank. And in the sewage tank was non-compliance of families, non-compliance of therapists not following manuals for EBTs, and patients not attending appointments, and a whole bunch of lists of things that confound the work that we do, like things don't go well. And that was what influenced outcomes. So what I've done is I've taken that and said, our EBTs have value. There's research and science, but if we put them into if we use evidence-based practice as to what they go into, that messy thing that we all do, then we will get better outcomes. So the NRF has this is one slide to just reassure you, because I'm going to describe to you this complex framework, but holds very, very dear basic psychotherapeutic tenets, and those are taught in the NRF. So the importance of working alliance, therapeutic use of self. The NRF has a special paradigm called heart, hand, and head that helps explain how we work with families. Dr. Lillis was criticized by folks in saying that there wasn't enough reference to cultural values and teasing out how to use this with different cultures and ethnic groups. So she did training herself in a curriculum and has brought that curriculum to the framework as well. And then again, I want to emphasize that it's for all practitioners. Okay, so now I'm going to dive into describing what this framework is. So Dr. Lillis wrote this complicated textbook, and as she was thinking about it, and the Harvard Center on the Developing Child was developing their resources of trying to describe complex neuroscience in simpler ways. I was learning this as well in Alberta because we have an initiative called the Alberta Family Wellness Initiative that was trying to teach folks about how to present neuroscience simply. What happened is Dr. Lillis took her complex textbook and decided, I can hang it on three key scientific concepts. And those are the concepts of toxic stress, serve and return, the importance of relationships, and the idea of brain architecture. And so we took these three key concepts and created three key steps. And so if understanding the importance of stress resilience versus toxic stress, if that's important, then we should assess for that. That's step number one. If serve and return and the quality of relationships is important, then step two refers and NeuroRelational. We need to assess the quality of engagement between caregivers and children. And then if brain architecture is important, then how do we sort that out? And that is the most complicated thing that we do. And so the NRF has a way of sorting that out, which I'm going to describe to you. So I'm going to ask you to have a whirlwind journey with me in the next 28 minutes. to understand how we sort out the complex and the messy, but I think the right and more difficult path. This is one of our newest, freshest diagrams, which I'm calling the blue planet. And I'm going to take you through each of these 5 paradigm shifts and 3 steps. So first step is sorting out adaptive versus toxic stress. And our first paradigm shift. So I'm going to ask you to think about how we interpret behavior. Each paradigm shift is looking at behavior in a different way. And so in our culture, we very much look at behavior through the lens of compliance. So this is a real challenge in our culture. And I get very many children referred to me because they're getting kicked out of childcare. This is a huge phenomenon in North America right now. And the presenting complaint is the child is not listening, they're refusing, they are defiant, and they have aggressive behavior. And so what I try to do as a reframe for the family and the child cares is that we need to look at this not from this interpretation of behavior of the child being non-compliant and potentially giving them a horrible label of ODD, but let's look at whether or not this child is actually feeling safe in that environment. And then understanding this behavior in this way will promote long-term resilience for the parent and child. And just one comment, the protective factors that I'm describing in each of these paradigm shifts come from the Center for Social Policy Change in the United States. And so what we did is we kind of have done this fancy organizing of the 3 steps, these paradigm shifts, in the context of these vital competencies that this organization is looking at, these protective factors. So let's talk about the quest for safety and this idea of threat and safety in the environment. So this is a slide that describes the work of Stephen Porges and how we understand states of arousal. This is one way of describing states of arousal and how the nervous system perceives the environment. So in a nutshell, our nervous system is scanning the environment at all times to see whether or not we are in a state of safety, where we can be in a calm, alert state, or whether or not we're in a state of danger. And in a state of danger, we mount a fight or flight response if it's extreme. And then life threat, we go into a state of being flat or sometimes non-responsive as a way to defend ourselves. The NeuroRelational framework is looking at that life is not always about danger and extreme threat to life, but that we often experience every day, all of us, challenges. Children experience challenges, as do we as adults. And that having stress responses and having variability in how our nervous system is functioning from minute to minute helps us adapt to how we're dealing with our day. And there's a little bit extra complexity here, because it's not quite as simple as just brakes and gas. Sometimes we have brakes and gas co-activated at the same time. So what we've done is we've created some tools to describe this to parents in a simple way. And so we actually hand out this information, these pies. I'll show you another handout that we give as well. And so I actually give this information directly to parents, and I teach them about states of arousal. I don't use that phrase. I call it how we are throughout the day, our states of being, and stress responses. So what I describe to parents is that we need to be in this calm, alert state to grow and thrive and do our best at work and play throughout the day. And just right looks like bright, shiny eyes and calm and alert. And stuff happens throughout the day, which is a challenge or threat, and children and adults can have the gas pedal on, and that leads us to be sometimes irritable, sometimes aggressive, frustrated, or flitting. We describe happy red zone as well. This is where kids are at treehouse or adults are at a party we're in the happy red zone with the gas pedal on. And then the breaks are where we are couch potato as adults, glazed over at the end of the day in front of the TV, and flat, bored, withdrawn. And the combination zone, this combo zone, is where gas and brakes are on together. This is where we often feel anxiety, fear. When we're immobilized, when the brakes are on and our heart is racing, that's where we have a freeze response. Literally, a deer in the headlights is in having a freeze response. And panic is where there's more of the red zone and we actually can get up and move. But are feeling that anxiety. The Harvard Center describes stress this way, as positive, tolerable, and toxic stress. And when I heard this presented, I said, this is very interesting. Yes, this is how our nervous system functions. We need to tolerate stress and have stress resilience. We need people to help us co-regulate and help us be calm again. But toxic stress, per this definition, is really about the stressors. So what does toxic stress actually look like? The NRF uses the work of Bruce McEwen to describe toxic stress patterns. And so what I describe to parents, I have a handout that I give. I'm going to start using this one because it's new, but I have a little stressed out dude, and then I have these 4 patterns described. Basically, toxic stress patterns are if we have those 3 stress responses, any or all of them, too frequently, too quick, 0 to 100, and too intense. That is the first pattern. The second pattern is tricky transitions. So having difficulty transitioning from one activity to another. That is a very common problem for many, many young children. Not adapting to typical challenges throughout the day. The second pattern is taking too long to recover. And our understanding of physiology is mostly 20 minutes for a young child. That would be the longest that one would expect a stress response to last. If a tantrum lasts longer than 20 minutes for a 2 or 3-year-old, that is a serious problem. They are in a state, this is a toxic stress pattern. And then the fourth and worst pattern that trumps the other 3 is not getting back to baseline health. So not adequate green zone during the day and not having adequate sleep at night. So this is a handout that we give to parents, and this is a way of us describing brakes and gas, the green zone in the middle, and this idea of the combo zone of both brakes and gas being on together. And we use the metaphor of driving, which sometimes helps, that when we all should drive a car in the green zone, hopefully, when we're calm and alert. The red zone in its extreme form is road rage, but also swearing when someone passes you abruptly. The blue zone is where you've driven blocks and you're zoned out and you don't remember, or you turn the wrong way because you're on autopilot. And the combo zone is when you hit a yellow light as a learner, or you hit ice and you're literally brakes, gas, and you have that surge of anxiety. So what is recovery from stress? Recovery from stress is having good quality sleep and having that capacity to maintain calm and alert through the day. Green zone is where we're just right for our learning, our sensory comfort, and relational joy. So now I'm going to present a case to kind of hold these ideas and kind of bring it to life for you as to how we use it clinically. And so my case that I'm presenting is an infant. I'm going to present a bit of longitudinal data because I've followed this child for a few years. Presented at 10 months, a twin who was described as always on edge, startled easily, had long periods of crying, and basically met criteria for all 4 toxic stress patterns. And we used the pie to describe to the parents and sorted it out together, co-created these pies. And basically this child was in the green zone on difficult days 20 to 30% of the time. The rest of the time, she was not a happy baby. She looked like this baby, hypervigilant. And our goal was to get her to be green more of the day. When this baby was 3, the family participated in a little study that we had about trying to use wearables to see if actually children and parents would wear watches to monitor physiological responses, and using a phone app to tease out those stress responses. And actually, our feasibility study showed that parents and kids are resilient and they will wear and do these activities. But interestingly, at 3, what we found is that the parent, and the parents wearing the watches too, by the way. So what we found is that the parent's physiology and the child's physiology matched. They both had stress responses nicely together. The other interesting thing we found for this little one, which we observed clinically, is that the little triggers throughout the day would precede a big meltdown. And parents, we all know this as parents ourselves and in our own bodies, that it just, you're monitoring sometimes these little stress responses, and then a big one tips you over the edge. Okay, so that was a brief whirlwind description of step 1, understanding stress responses, describing them really clearly. We have handouts where we detail what eyes, face, body posture, movement look like. So parents can go home with the pie, with that little arc chart that I showed you, with the handout of what each of those zones looks like. And then they come back and use that language with me, and then we co-create pies. And we track improvement in how things are going as to whether the child is more green. Because that's, green zone is what grows the brain. Green zone is what helps us build resilience. So step 2 of the NRF, relational, is about sorting out quality of engagement. And most of our EBTs in infant mental health are about improving quality of engagement. But that is not the whole story of infant mental health. It's a piece of our pie. So paradigm shift 2 goes with step 2 nicely. And this is, our shift here is asking folks to think about how we look at behavior, what our responses to behavior are for young children. And currently, sometimes we get stuck in the paradigm of looking at children's behavior as good or bad. We can be very judgmental. Dr. Lillis and I were on a phone call, and we were thinking about this paradigm shift, and we do this brainstorming, and I was saying we need to create a list of all the horrible things, all the words and phrases we use to describe young children's behavior that is really judgmental and describing children as being bad, because we have quite a bit of it in our culture, which makes me very sad some days. And the goal here in this paradigm shift is to shift from thinking of behavior as good or bad and then needing to be rewarded or punished, but looking at it from the point of view of providing relational safety. And again, that is what most of our EBTs in infant mental health are focused on, is improving that quality of relational safety. And the protective factor that we're going for is improving social connectedness throughout the lifespan. So the other thing about that my parents tell me, and that I've experienced myself with my own children, is that if your child is bad, then of course you're a bad parent, because you're allowing your child to have a tantrum in Walmart, right? It's like your fault that your child is tired, hungry, or just cranky, or sensory overstimulated, right? And we have, and this is a study, I don't know if you guys have seen this study from 0 to 3, it's just out in the last few years, surveying American parents as to what they think little kids can do. And so 24% of all parents of young children think that kids can control their emotions and not have a tantrum at about a year. And 42% believe by 2 years kids should be able to control their tantrums. So to control that red zone stress response. Not physiologically possible. So what we teach parents as kind of part of this idea of creating relational safety is that stress responses are involuntary for all of us. Under states of severe challenge or threat, we will all have stress responses. Young children's nervous systems are immature, and so they need more help to get back to being green zone. They need co-regulation. And so how co-regulation happens for any two humans is one person's got to be calm to get the other person calm. So you as clinicians, you need to be in the green zone as much as you can to help your the children you see and their parents stay calm. So we talk to families about recognizing their child's stress responses, recognizing their emotional states, and figuring out what they need, and then co-regulating to help the child get back to being green. And we use this diagram actually and show this to parents. And I'll just put my glasses down so I can do the little gesture demo. So we use this, and this is from the book of Samaroff, that's Treating Parent-Child Relationships. This diagram comes from that. Dr. Lillis adapted it because I'll tell you that story in a minute. So I described to parents that children, when they start off life, babies have this much capacity to self-regulate, and that they need the other around them to help them get calm. And that as children grow, that cylinder or the cone in the middle gets bigger, and we have more capacity to self-regulate. But throughout the lifespan, we need others to help us from day to day, minute to minute, to stay calm. Humans, we are very social animals. We require other brains around us to regulate ourselves, to aid that self-regulation. And very smart residents say, Dr. Hapchyn, flip the cone, because that's what happens when you get sick or when you get old, is that you then have a deterioration in your capacity to self-regulate. And that can happen to any one of us. If any one of us were admitted to emergency in the next hour with a medical struggle, our capacity to self-regulate would go down, and we would be very much relying on all the others around us to keep us as green as possible. So we talk about co-regulation of stress responses, and we talk about social emotional milestones. So this is something we don't do well in our work, is actually break down what are our social emotional developmental milestones. How are we together, and how does that develop over time? So Dr. Lillis adapted the DC0 to 3R dimension 5, axis 5. That was created by Stanley Greenspan and Srita Weeder. Comes from the DIR model. She adapted that, those developmental milestones, to create this pyramid. So I hand this out basically to most families I see, whether their child has autism, whatever the diagnosis is, to help them understand their child's social emotional development. And so in the handout that you will get, you'll be able to read it. So let me just describe the milestones quickly. The first one is being green together. So we cannot assess capacity to be with someone else unless we're both calm. The second milestone is seeking comforting connection. We adapted that to expand it to all our senses, not just eye contact. The third milestone is sharing joy, so that we have those brief moments of joy that we share between each other. And then we build circles. So Greenspan and Weeder created that idea of circles of communication, which the Harvard Center has adapted to serve and return, that back and forth that happens. And then we expand with wonderful gestures that we change our body posture. We use our hands and arms. We use our face to amplify the message. And those are the bottom-up social emotional milestones that are well established by 12 to 18 months of age. And then we build the nonverbal or the verbal milestones of language, symbolic play. And then the last one is being able to really use language in a complex way to solve problems and negotiate and get cookies before dinner. Okay, so I'll bring you back to the little infant. So just really briefly with step 2, we did a lot of relational work to support the dyad, of course, and actually the triad, because the dad was extremely invested. And then we actually had 4 people, because we had a twin, and then a 5th baby, or a 3rd baby. So was born actually about 10 months after these twins. So there was triplets almost in this family. So, but just so far as the NRF component of the relational intervention, it was really helping reframe the behavior as stress responses for this infant, that they had a very sensitive child who needed a lot of co-regulation, and that the family was very anxious about this baby because when the baby was in a stress response, a good chunk of the day, there was not good eye contact, and some of those social emotional milestones didn't look so robust. But when the baby was in the green zone, absolutely healthy infant with the typical social emotional capacities. So helping the parents understand that help motivate them to really work hard on that co-regulation. And then make the most of the green zone moments. Okay, so now I'd like to describe step 3. Paradigm shift, number 3 here. We need to help folks that do work in the field as well as our parents understand parent-child development better, because we have a lot of misconceptions. I see lots of families, I'll give you just one example. Chaya talked about sleep, toilet training's another. Lots of folks having very unrealistic expectations about what kids can do and how they can manage their bodies. So having a neurodevelopmental lens can help us understand what kids can actually do. And the NRF really talks a lot and kind of organizes our understanding of how the brain works and kids learn into top-down and bottom-up capacities. And the brain is built from the bottom up, and so we need to address bottom-up brain function first with little kids and not go too high too fast. And so when we're interpreting behavior, mostly for our little ones, their behavior is bottom-up, automatic, without thought, procedural learning, learning through doing, nonverbal memories. Top-down capacities start to come at 18 months, but as I tell parents, frontal lobes are not online until well after 3.5. And so we need to not infer a lot of intention and thought and planning to little kids' behavior. And then when they are coming online, they're very simple. And so we need to align our treatment approaches the same way, bottom up and top down. And bottom up approaches are really focusing on procedural memory, procedural enactments, and the need for, as I've talked about, co-regulation, sensory motor strategies. And then when kids are ready, then we can use more top-down approaches. So for the case, what I was explaining to the family when this infant was little is that we needed to be detectives and sort out what was triggering this child to have stress responses, what was she remembering because she was laying down procedural memories of things that made her stressed and anxious, and then what could we do to recognize those cues, avoid those triggers as much as possible. And now that she's 3.5 and has lovely language, she's able to describe to us what bugs her, and we're able to use more top-down strategies to help her with her anxiety. Paradigm shift number 4. So we're organizing this as kind of step 3B. And this is one of our most complex steps and to figure this one out, you'll see, requires a bit of, again, detective work. And this is where we require major cross-sector, cross-discipline sorting out the case. We need to stop thinking about behavior having simple causes and simple solutions. That is our status quo. We're going for magic bullets, and for lots of our kids, there's no such thing. They present with very complex challenges across domains of development, and we need to be able to sort that out. And it's when we sort all of the pieces of the puzzle out, it's then that we help the family and child, that's where we'll get optimal social emotional competence. And when I see that word social emotional competence, I always think of Sarah Landry's work and those building blocks that she described in her lovely book of how much it takes for a human to be competent. And the steps, multiple steps. So how the NRF helps us organize that complexity of all the causes of behavior is by organizing how we think about the brain, how we think about brain development and function. And so the NRF in the textbook goes through in exquisite detail 4 brain systems. Starting from the bottom up, the brain system, the whole neural networks that help us manage our inside body world, sensory world, relevance and feeling, and then our executive. So what I describe to parents is that when we start off life, there's a lot of work that needs to be done in development and brain development specifically, but in our body too, of getting our body calm inside. So organizing our hunger satiety cycles, our sleep-wake cycles, temperature regulation, and how our guts are working, and peeing and pooping, all those fun things. And then we take in information from the outside world, actually starting in utero. We're taking in sensations and organizing them and making sense of them. And then, again, early in infancy, sorting out, is that a positive experience or a negative experience? We start that sorting hat from very early on in infancy, and then we layer emotions as to how it feels in our inside body world and how the outside world feels to us. And then we lay down memories of that. And we make meaning of it as we get older. And then the last part of the brain to develop is that executive functioning, which relies on the information from all the rest of the brain to how we adapt to the outside world, and how that's our thinking brain. And our brain that manages our movements and how we respond to the world. So we can organize our intakes, our assessments, our history, data collection into these 4 brain systems. And it works very neatly. And I've been working hard on organizing an intake. And I can tell you it's a work in progress. I keep cutting and slashing and trying to pare it down to make it, doable in an hour and a half. And it's a huge task. But we can organize how we collect data into these 4 brain systems. And then we can then understand the individual from the point of view of these 4 brain systems and organize our systems of care around these 4 brain systems. So it very neatly works out that our social services and our medical system help take care of our basic needs, our inside body needs. Our developmental disabilities folks, OTs and PTs, take care of the sensory world. Mental health is siloed into our memory and feelings brain system. And then our learning is taken care of, our higher functionings of thinking and planning and learning by our early care and education system. The case I have here, I'm just going to quickly describe how we, just to give you an idea of how function sort of sorts out into these 4 brain systems. So for the little one that I saw, she had reflux, she was hungry, which triggered stress responses, and missing a nap, restless legs in her sleep created troubles for her. So then we targeted those troubles with some strategies. We sorted out her sensory world. She had a mixed kind of picture. If we look at DC 0 to 5 diagnoses, she was sensory seeking, but also sensory sensitive. So we educated the family as to what they needed to provide her with sensory-wise or avoid. She developed more and more anxiety as she got older, experienced separation anxiety. So again, teasing out that component of her development and providing appropriate strategies. And then likewise, we sorted out her motor needs. When she was little, she got, that was another trigger for frustration and stress responses, is needing help to walk. She was very irritable. And then once she was able to walk, she was then able to more self-regulate her sensory issues because she could get away from stuff or approach stuff that she wanted. And then as an older child, using visual schedules, social stories, and routines helped her. So you can see, I've just given you a really quick whirlwind, but you can see how we teased out the troubles, the challenges, and the strategies, brain system by brain system. Our last paradigm shift is about needing to work together. So I referred to that problem of fragmentation in our field. We need more integrated approaches. We need a common language, and that's what the NRF is hoping to provide, because what supports resilience for families is having the support they need when they need it, that actually works. And we need to figure that out more quickly. So as you can sort out troubles and diagnoses and challenges per brain system, we can sort out all the folks that help into their primary brain system that they are more oriented to. So you guys will have this slide. Mostly includes everyone. When I was looking at it last night, I thought, okay, we don't have early intervention in there, and we don't have child welfare caseworkers on there. When I present this information to those folks, I say, you guys are kind of in the middle. you have to be more transdisciplinary, and you have to kind of absorb a whole bunch of information quickly to help the kids and families that you serve. We can organize our systems more effectively using this paradigm of the NRF. We have that purple wheel in the middle, and the idea here is the values of shared approach, common language, and a comprehensive relationship-based intervention could affect the systems, all our systems of care across sectors. And in Edmonton, I'll just really quickly, I've got 8 bubbles here. So just by the process of sheer determination and word of mouth, we've offered workshops to all these folks in our community. And so we are actually starting to have a shared approach and common language. So I have kids that have been referred by early intervention, and the families come in and say, yeah, I know those colored zones. My kid's in toxic stress. That's why I'm seeing you. You're going to help me figure it out. And that's really cool to have families coming in already with some of the language. We can use the framework to actually sort out how our EBTs kind of map out. Are they kind of covering all the bases? Which bases do they cover? That may help us sort out which EBT is useful for which family at which time. We might be able to talk more about this during the panel.
Yeah, for sure.
Okay, so 2 final comments. The NRF was written in 2009. These research domain criteria written by the National Institute of Mental Health came out in 2013. And they're looking at domains of functioning to do research on in mental health. And very nicely, they match up to the description of the NRF. It's quite amazing. And this is a total different set of folks working on the same problem of how do we sort out our messy world, and they're coming up with similar domains. Whoops. A little bit about the case. These are all the people that were helping that little gal. So last slide. We are hoping that the NRF can help bridge the gap between our trauma-informed movements and the neurodiversity movement, so that we are not looking at development and trauma separately. We can bridge the gap and understand that we need to work with both for all families. The NRF helps explain the impact of toxic stress really well. It helps tease out what are stress responses so that families and clinicians can really understand it in a simple way. It describes what toxic stress patterns are very clearly, and families get this in 1 session. And then the hard part is sorting out all the factors that contribute to the complexity of cases. But the NRF gives us a map of using the brain to guide our practice, these 4 brain systems. And then we can organize our systems of care in a similar way. And then the idea is if we can do all that, then we will have improved family health and child health, which then we have an iterative cycle that we decrease trauma, we increase developmental outcomes, and then this whole cycle is repaired. So I will look forward to questions, maybe a little bit now, but mostly at the end of the day.
Yeah, let's take at least 1 or 2 questions right now. Anyone have any questions?
Your brains your circuits are fried.
Well, I wonder, the adaptive versus toxic stress, because that was something that I found interesting when Connie talked about it, because the Harvard folks don't really talk that much about it.
Right.
Wonder if you can just talk a little bit more about that.
That's a good question. So I think it's important and actually one thing I wanted to tell you, which I'm going to tell you now, because you can just percolate on this throughout the day. Think about your own stress responses. So the NRF, in teaching the NRF and learning the NRF, one of the key tenets is that you apply it to yourself, because this isn't a description of how someone else's brain develops and grows and functions. This is a description of how all our brains and bodies function. And so those stress responses you can apply to yourself. So I can give you an example. So on the plane yesterday, I was feeling a bit combo zone, because I do get that way on flights. And so I was recognizing those stress responses in my body as an adaptive stress response. I'm leaving my home, my family, and their challenges, which I'm a fixer, and I have to come to a meeting and I have to present 45 minutes of information, which usually I do in a long period of time. Blah, 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 blah. My brain's going, that's combo zone. This morning, I was really working hard on my blue zone because I was up at 4:30 actually, Edmonton time. And then thinking, oh my goodness, you're going to be in the blue zone and you have to present for 45 minutes on your feet and be with it. And so I was thinking about myself being blue zone and then channeling, okay, what are the resources that you can have to get yourself self-regulate back to green? I had a lovely hug from, actually had multiple hugs from people, which helped co-regulate me to get me to green. So these are all adaptive stress responses. Did I have a red zone response? Probably a little bit on the gardener. When we were sitting in the bus this morning, little frustration and irritation, and then looking at, you know, the eroded concrete. And like, okay, are they gonna, what's wrong with, you know, the city of Toronto? Why aren't they? Yeah. So that's adaptive, that's a description of adaptive stress responses. Was I in a state of toxic stress? No. Adaptive stress, self-regulating back to green, using my peeps to co-regulate me back to green, versus toxic stress, which I define by those 4 toxic stress patterns. Multiple triggers, 4 toxic stress patterns.
Yeah, and I guess part of what our role with families is to help build those adaptive mechanisms or strategies.
We have stress responses. Yeah. That is just the way we're wired. How do we develop strategies to self-regulate as adults? How do we help our children develop strategies to self-regulate? What I explain to educators and parents is that kids don't don't come with self-regulation. They learn it, and they learn it through their relationships with caring adults in states of safety. Right. In safe relationships with adults is how kids learn to self-regulate their stress responses, their sensory world, their emotional world, and their thinking.
Great. Okay. One more question. I know we're a little bit late for break, but we'll adjust. Hold on.
Sorry. Hi. In the beginning, there was a picture of a book. Is that research that you had done?
So the book is written by Dr. Lillis and Turnbull. It is a textbook. I can provide more information about this later in the day about the training and what we're doing, I think. That might be, thank you for the segue. We'll hold it and then we'll talk a bit more about the resources and the training at the end of the day.
Okay, so everything you presented is that was discussed in the book?
It is in the book.
Okay, thank you.
And it's summarized on the website, highlights on the website. And Dr. Lillis is, and I'm supporting her work in creating a manual that is not a textbook, that is user-friendly, that is in steps, so that we start off with paradigm shifts, foundational information that everybody should know. And then if you want to nerd out and really dive deep, then you can take the nice bite-sized chunks.
I think one of the neat things with this approach is also that watch, wait, and wonder can fit into the NRF.
Yes.
You know,
all the EBTs that we're going to hear about today have a place in the work we do.
So this becomes sort of a place. I think when I was taking the course with Connie, I thought of it as a placemat almost. And there was a place where I could put different interventions that I knew into that framework, which can be really helpful when you're trying to build a system.